Welcome to the Alabama Public Health Training Network. Tobacco continues to be the leading cause of preventable death in the United States, despite overall prevalence rates decreasing in recent years. Today, we will discuss brief interventions and resources that healthcare providers can use to help encourage tobacco users to kick the habit. Thank you for joining us today for our program, Treating the Tobacco-Dependent Patient, Interventions That Work. If you have a question about anything being discussed today, please call or email during our broadcast. The telephone number and email address are on your screen now and will appear again later in the program. Also, the handouts, sign-in sheet, and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, CE credit will only be awarded for 1 year and will expire on March 31st, 2016. I'm Karen Atkinson, manager of the Quitline, and with me today is Julie Hare, director of the Public Information Unit for the Tobacco Prevention and Control Branch, Leanne Hickson, Plan First manager, Irul Patel, intern with the Alabama Medicaid Agency, and joining us by phone is Seth Skelton, Client Relationship Manager with National Jewish Health. Welcome to everyone. Now, first up, we have Julie Hare with the Tobacco Prevention and Control Branch, and she will be speaking to us about the AARP intervention. Julie?
Thank you, Karen. You know, we hear it so often when we're out there. People say, I don't smoke. I don't know anybody that smokes. I'm not around anybody that smokes. You know, tobacco doesn't really affect me, but that's not really true. We all know people who smoke. We all know people who are affected by the terrible diseases that tobacco can cause. For instance, in the United States, every year, 438,000 people die annually from smoking. There are 42,000 deaths annually from exposure to secondhand smoke. Tobacco affects all of us. 16 million people suffer every day from a smoking-related illness. 29 million people in the United States, 29 million children are exposed to secondhand smoke at home each year. In Alabama, we are seeing a little bit of a decline in the smoking rate, but it is still one of the highest in the nation. 21.5% of adults smoke. 18% of our high school students are smokers. 8,600 children in Alabama, let's start over. 8,600 Alabamians die every year as a result of their own smoking, and 289,000 children are exposed to secondhand smoke at home in Alabama. As I said, we still have one of the highest prevalence rates in the nation. We're also seeing a new challenge. A new trend that we're seeing is the e-cigarettes, and we will address that a little bit later on. Here's the good news. The good news is that almost 79% of us are not smokers. But the bad news. Tobacco users are disproportionately low income, have low socioeconomic status, and have lower levels of education. The tobacco industry is very well funded. It spends $8.37 billion annually in the United States to promote its products. It targets specific populations. For instance, African Americans, the marketing is targeted for menthol cigarettes. African American men have some of the highest rates of lung cancer in the United States. For youth, the tobacco companies are targeting youth by the very colorful advertising. I challenge you to go into any convenience store and see what products are being marketed. There you can tell, if you hold a candy bar wrapper up against some of the tobacco products, there's very little difference in the packaging. They are promoting snus, smokeless products, anything that maybe a child could use, and perhaps in a school setting or someplace where people wouldn't know that it was being used. They market to women. If you've ever seen the tobacco ads, you will notice that the women in the ads are very thin, they're very independent, they're athletic, they're having a wonderful time, seemingly, according to the ad. For Hispanics, the tobacco companies market to them by providing Rio and Dorado brands of tobacco. And to American Indians, American Spirit tobacco is promoted. And I was looking at an ad this morning for American Spirit, and it's marketed as a natural tobacco product without any additives. There are a lot of photos of celebrities who are using the American Spirit brand of tobacco. So we have a lot to do to go up against that $8.37 billion that tobacco companies are spending in our nation. So why should why do you care about tobacco, and what is your role in helping us promote the Quitline and quitting, and how can you help us to do this? Well, first of all, let's say that, and I know this was mentioned earlier in the program, tobacco use is the leading cause of preventable death in the United States. If we could get people off of tobacco, we could save so many lives and so many people from suffering so needlessly. Tobacco use is a chronic and relapsing condition. It is not a habit, it is an addiction. One way that you can help us is that we know that 70% of smokers see a doctor annually, and more than 50% of them will see a dentist annually. This is a captive audience. This is your chance to bring up the issue of tobacco cessation. We have evidence-based interventions that exist, and they are cost-effective to use. And we know that if you address tobacco use with your patient, it also leads to higher patient satisfaction. The majority of tobacco users want to quit. 70% of all tobacco users want to quit. I can't think of anyone that I've ever talked to about tobacco use that said, gosh, I sure do want to keep smoking. Gosh, I hope my kids grow up to be smokers. Most people really want to quit tobacco. And we know that 40% of them try to quit at least once every year. And at any given time, 20% of all tobacco users are ready to quit. So that means, based on our state population and our prevalence rate, at any given time, 160,000 adult tobacco users are ready to quit right now. Some of them could be in your office today. So what's the next step when they come into your office? We promote the protocol of Ask, Advise, Refer, Prescribe, AARP. It's quick, easy, and non-intrusive. So let's talk a little bit about it. Many of you are probably familiar with the 5 A's. The 5 A's have been around for years and years. It is the gold standard for brief tobacco intervention. You're going to ask every patient, advise them to quit. You ask if they use tobacco, advise them to quit, assess their willingness to quit, assist with a quit attempt, and arrange the follow-up contacts with your patient. That is the gold standard, but it takes about 10 minutes to do. And it's something that maybe you don't have the time to do. As a matter of fact, you told us that while the 5 A's is a wonderful thing, you don't have 10 minutes to spend on just tobacco cessation with each person. So we have reduced it to Ask, Advise, Refer, Prescribe. It is the abbreviated version of the 5 A's. It's a time saver, but it ensures that the full intervention is going to be completed with your patient. There's also one additional benefit to this brief intervention, whether it's the 5 A's or AARP, and that is, let's see if I can get to the right side, recording and providing the cessation intervention meets a core clinical quality measure that can be used to demonstrate meaningful use. Now, meaningful use and electronic health records are a whole other webinar, so we're not going to go into it very much today. But I just wanted to mention this so that you would be aware of this. So here's how AARP works. We want you to ask every patient at every visit, do you use tobacco products? We say tobacco products because if you just ask if they're a smoker and they use other products, then they're going to say, no, I don't smoke. I don't smoke. But what you want to do is document any kind of use of tobacco products. If they're over the age of 10, these are the patients that we want you to ask if they use or have ever used any tobacco products. If they're under the age of 10, then you should ask their parents or their guardians about their personal tobacco use, because this secondhand smoke could affect their health, respiratory illnesses or ear infections. So document these responses in the patient's medical record. And also, you might want to mention e-cigarettes as well. Go ahead and document that and put that in their records as well. Then we want you to advise your patients to quit. If they are a tobacco user, this is not the time to be wishy-washy on the subject. This is something that, they are expecting. You're the healthcare provider. They are expecting you to say something about tobacco use. We want you to be clear. We want you to be strong in your message, and we want you to personalize your message if you can. The clear advice would be, it is important that you quit smoking. How can I help you? Or, even if you only smoke a couple of cigarettes a day, it's still dangerous. The strong advice would be, as your doctor or your clinician, I need you to know that quitting is the most important thing that you can do. This can help all of your health situations. The clinic staff and I can help you do this. As far as personalized advice, you can talk about how their health condition is made worse by any kind of smoking or tobacco use. That if you also know their family history, you might mention about if other family members had lung cancer or COPD or other issues, that this is not what you want to happen to them, so that hopefully with your advice it will help them quit. You don't want your patients to interpret your message as any other thing than quit all tobacco use now. And they are listening to you. I know that many people think that it goes in one ear and out the other, but they're tucking away this information if you will just advise them to quit. So think about their motivation levels on a scale of 1 to 10, with 0 being the lowest and 10 the highest. How ready is that person to quit tobacco? And here's what, let me turn some page. Here's how you're going to tailor your message to their motivation level. If they're a 0 to 3 and they're just not really that interested in quitting, you can offer them some information, give them some educational materials on quitting, and tell them about the Quitline. If they are moderately motivated, you can encourage them to call the Quitline, ask about specific concerns, and provide some literature on quitting. Or if they are highly motivated, you can tell them that's the best thing they can do is to quit. You can discuss some medication options. And Ira will be talking about what FDA-approved cessation medications are out there. And then you can complete our Quitline referral form. The highly motivated patients are probably the ones that are going to be much more likely to use our Quitline services. So we want you to refer them to our Quitline. Our Quitline, provides free cessation services. It is a free call. It's a 1-800 number. We have a free online site. We offer free coaching and free nicotine therapy replacement patches. Now, you must be medically eligible and enrolled in coaching in order to get those patches. So why do we have Quitlines? What is the point of a Quitline? Quitlines are reliable. They're accessible. For people who might not have time or resources to address tobacco dependence intensively, you can safely and with confidence refer people to our Quitline because we are an evidence-based treatment. There are other treatment modalities such as in-person groups, classes, tobacco cessation clinics that are also evidence-based, but we don't have that many in Alabama, unfortunately. So the quitline comes into when barriers are, there's no time to help people quit smoking, there's no resources. You can feel confident in referring people to our quitline. It is a 1-800 number, as I mentioned earlier. We are open from 6 to midnight, 7 days a week. All states have a quitline. All services are just a little bit different with each one. In a few minutes, our client relation manager, Seth Skelton, with National Jewish, is going to tell you exactly what, some more details about our Alabama Tobacco Quitline. As I said earlier, we are a free telephone and online coaching. We have specially trained cessation coaches to help you. You are eligible for up to 5 coaching calls for any tobacco user. We have the free therapy, and we also have the mobile apps, texting, and an email program. So when we talked about earlier that you must be medically eligible to receive your patches. This just means that you are not pregnant or breastfeeding, you don't have uncontrolled high blood pressure, you don't have a recent heart attack or a recent stroke. So if you have one of those conditions, we're going to ask your doctor to sign off before you get the patches. Also available at at the Alabama Tobacco Quitline, we have coaching services in Spanish and English, and other languages are available via the translator service. We can send you the Breathe Easy Guide, which is a written guide to help you stop smoking, and we can refer you to a local cessation service when requested and available. We have several methods of referring patients to the Quitline. We have some materials, Quitline printed materials, that we will be more than happy to send you if you will send us an email. Our email addresses will be on the end of this program. We have cards that you can hand to your patients with the telephone number. You can tell your patients about the Quitline, but our most preferred method of referring to the Quitline is through our fax referral form. And our fax referral form is with the handouts for this webinar. You can find a copy of them. It's also on our website. It's on our Alabama Quit Now website. Excuse me, our Quit Now Alabama website. And we will be happy to send you some of those cards if you want to hand them out, or if you want to use the fax referral form that's on our website. Ira will talk about the Medicaid fax referral form in just a little while and how to use it. The patient must sign off. Here's a copy of the fax referral form that we use. You will sign. As a healthcare provider, you will fill in the blanks. You will have your patient sign off on it, because the patient must sign this form in order for the Quitline to call them. And some of the benefits of this fax referral form are that it's going to allow us to make that proactive call to the referred patient. If you just hand your patient a card and say, call, we might never hear from that patient. But if your patient signs off and lets us call, we think that proactive call, which will be made within 24 hours of the referral, can certainly go a long way toward making contact with that person and letting them know that there is free help for them to quit. As a provider, you can receive up to 5 feedback letters on your patient's progress. Excuse me. I think that will wrap up for what I had to say here today. We'll be happy to take any questions at the end of this call. We hope that you will refer your patients to our Quitline. Thank you, Karen.
All right, thank you, Julie. Up next, we have Seth Skelton with National Jewish Health, and he's going to talk to us about the Quitline in more detail. Seth, are you there?
Hi, Karen. Yes, I am here, and thank you for that introduction, and thank you to everybody else for joining today. I am excited to be able to share a little bit more about the program and what you as providers can expect after referring somebody, and what your patient can expect. So I'll just go ahead and jump right on in. So Julie obviously gave a lot of great information, so I'm going to kind of piggyback on a lot of what she said and refer back to her as well. But so one of the benefits of referring a patient of yours to Quit Now Alabama is, like she said, you know they're going to get calls, and we give 3 3 calls to each person who is referred over about a 10-day to 2-week period, just kind of how it plays out there. The first call is within 24 hours of making that referral. So rest assured, when you send in a fax or you fill it out online, that referral form, we're going to act on that immediately, and while it's still on your patient's mind, they'll remember, oh yeah, I talked to the doctor about that yesterday, and now I'm getting a call. So we want to act on those referrals very quickly. And one way for you as a provider to know about the progress of your patient and that we received your referral are the fax referral notifications, fax-back notifications that you'll receive from us. So as you can see, we'll send one out really as soon as we receive the fax, just to confirm, hey, we received your fax, and we'll be acting on this. You'll also receive notification when we have been able to enroll the patient who's referred. So we get a hold of them and they want to participate, great. We move ahead, you'll get notification. And also if, say, they decline to participate or they're unreachable, basically we're unable to contact them, you'll get notification on that as well. Later on, as they go through the program, if they're medically eligible, we will send them nicotine replacement therapy if they're interested, and that'll be in a patch form. And so you'll receive notification there. And you'll also receive notification when your patient has completed the program, or if, say, they don't complete the program, they don't want to participate, or at that point later on they become unreachable, then you will receive notification there as well. So you'll know how your patient is doing pretty much throughout the entire program. One thing that we don't say is if they are or not using tobacco, so that's not something that we have currently, but is definitely something that we'd like to provide, especially with electronic health records. And I think there may be some mention of that later on, but that's kind of the next step with health systems, being able to provide a little bit more detail on the patients being referred. One thing that I did want to mention is when you are filling out that referral form, if you're able to print it off and then fax it in to Quit Now Alabama's program here at National Jewish Health, and you sign somebody who may be pregnant, or somebody who's had a heart attack or stroke recently, maybe has uncontrolled high blood pressure, then we don't have to get extra consent later on. You basically are telling us, yep, this person may have some contraindications, some other health conditions, but they're okay to wear a patch, and go ahead with that. So that's always something to keep in mind on your part as a provider, just to remove an extra barrier to receiving NRT, because if somebody calls in or maybe they're referred, but we have to send them back to their provider to get consent for NRT, then that could slow things down a little bit. So we just try to avoid that as much as possible. So moving on to what a patient can expect in the program. So like I said, they're going to get a call within 24 hours. We'll let them know that, hey, your doctor referred you to our program. Is it okay if we tell you a little bit more about what we offer? And usually people want to hear about it, so we go ahead and give them some background and let them know about the benefits of enrolling. Like I said, we make 3 attempts over a 10-day to 2-week period. And if they do want to go ahead and enroll, we will go through an intake questionnaire with them that normally takes about 15 minutes. We get demographic information, smoking history. We do run through a medical screen just to try to get as much information before we actually go on with the coaching/counseling part of the program. And as mentioned earlier, we do offer 5 proactive counseling calls. So that is scheduled calls that a coach will make out to the participant in the program. And in addition to those proactive calls, we can take reactive calls, basically. So the participant in the program can decide to call basically whenever they need additional support within those scheduled calls, or even after completing the program, they can call back in and talk to us about what's going on. If they have questions or concerns, they just need to get some things off their chest. Maybe they've thought about relapse, or maybe they have relapsed and they want to get back on the wagon. Well, we're here to support them. And really, it's kind of unlimited calls. We won't cut anybody off. And in addition to our phone program, we definitely work to refer people to other in-person type groups or other online programs, anything like that. Really, the more support, the better. So we won't encourage people to use our program, but we know over the long term that there may be other resources that can fit even better with a tobacco user or somebody trying to quit tobacco. And when somebody does enroll in the program and they're medically eligible, they go through coaching. We start them off with a 2-week supply of free patches to help with the physical part of the nicotine withdrawal. And I don't want to let the cat out of the bag, but that benefit certainly could be changing very soon. To help people even more, we know that nicotine replacement therapy in combination with coaching drastically improves somebody's chances of quitting. And we all know how hard it is to break the tobacco addiction, whether it's you personally have done it or have seen patients, family, friends, whoever go through it. It's very challenging. And we know that it takes a very supportive, non-judgmental environment, and that's really what we strive for here at National Jewish. So just to give an overview of kind of what the coaching looks like, we support people throughout the entire quitting process. And like Julie mentioned earlier, there could be somebody who's really ambivalent about quitting. Maybe they're like low on that motivational scale. They're like, well, yeah, there could be some benefits, but gosh, it'd be so hard. I just don't know. If they're interested in the program, hearing about more, please go ahead and refer, because we're used to handling people who are somewhat ambivalent and not sure about where they want to go, taking the next step. So if somebody has quit already and they're struggling, or they just want some support, somebody who has already cut down, or somebody who is just not sure, we can meet them where they are and then offer support throughout the process. We even offer relapse prevention counseling as well. So we know that people who quit aren't guaranteed to stay quit for the rest of their life, and to have a plan after quitting, is really important. And so how we do that is we don't have a cookie-cutter approach. We know that every tobacco user is unique, and we treat them as such. We try to, when they call in, we want to see where they're at, because we know everybody is different. And it's funny because we use some of those same tools to ask about how motivated they are to quit. We ask those scaling questions about motivation, and then their confidence and their ability to quit. And then that kind of helps us to gauge our response. I'll go into this a little bit more, but the stages of change are, really the basis of how we begin an interaction with somebody. So, and like I said, so I'll talk more about the coaching aspect momentarily, but just one more thing about the program. We're open 7 days a week, as Julie mentioned, 6 a.m. to midnight, and we can accommodate inbound calls. We can accommodate a scheduled call pretty much any time within that window. So if somebody has kind of an odd work schedule, or, they have kids, don't worry, we can support them and accommodate by scheduling calls when they're convenient. So let's move along to just a little bit more about motivational interviewing. And stages of change goes hand in hand with motivational interviewing. And really what motivational interviewing is, it's a method for pulling out a tobacco user's own intrinsic motivation for change and to be healthier. Most people want good things for themselves, for their family, for their children, everybody around them. And so we try to highlight their own internal feelings and own desires. And we collaborate with people. We express empathy. It's like we're on the same team with the tobacco user. I think everybody who's been a tobacco user has come across this situation, and maybe you've heard other people express this as well, that the more they're told not to smoke, the more they want to do it. It's for a lot of people who began smoking as teenagers, it may have been a rebellious thing. It was a way to relieve stress, and it's really like their best friend. It's a way to just get away from whatever might be upsetting them at the time. So we want to do the exact opposite. we want to reduce resistance to the idea of making a change around tobacco use. We frame it in the perspective that it's the tobacco user's decision to quit. Because when somebody tells you to do something, especially if it's something that's been a part of your life, to get rid of this thing that's been your stress reliever, well, there's a really good chance that that's not going to go over too well. And research has shown that. So with motivational interviewing, it's really putting the onus back on the tobacco user to develop their own plan. We support them, but we certainly do not want to tell somebody what to do. And so this was first created by Dr. Bill Miller, and any of our coaches here in the program can tell you all about Dr. Bill Miller. We've watched lots of videos, we've read his literature, seen him in action in all different kinds of situations, and we do a lot of training based on Bill Miller and his philosophy of motivational interviewing. So, like I mentioned earlier, the stages of change, or SOC, as we use an abbreviation, are really important, and that's how we kind of judge somebody's motivation or readiness to quit when they start with the program. So somebody who's pre-contemplative, is not thinking about it really. They're not thinking about making a change just yet. Somebody in the contemplation stage is ambivalent. They're thinking there could be some pros to quitting, there could be some challenges to quitting, but it's a thought that's crossed their mind. Somebody who's preparing to quit, this is something that's really important to them, or at least they feel like they need to do it, and they're starting to potentially get a plan in place. Action stage, this is somebody who's cut down. They've already started with a support program. Maybe they've started to change routines. They've removed ashtrays. Maybe they're telling people around them they want to quit. And then maintenance stage is somebody who obviously has quit, and they're hanging on to this new lifestyle. For some, it's really challenging at this point. Others, they gain confidence each day. And so once again, that's where we want to identify where somebody is on this stage of change model. So to give some example, if somebody is in a contemplative stage or pre-contemplative, it would really be inappropriate for us to start talking about how they're going to quit, because they don't even know if they want to quit. So to start saying, well, how are you going to do it, and this and that just doesn't fit with where they are. So at that point, we would use some other techniques. We would maybe use a decisional balance, and this helps us to gain rapport and build relationship with the person, because we're trying to understand. We don't want to tell them what they need to do. Everybody knows that tobacco use is unhealthy. Everybody who calls in says, yeah, my doctor's told me, I know it's terrible, I don't feel good, I know I need to do this, but getting that motivation and courage to actually do that is the challenge. And so we want to let them know that we're not going to judge them, and they can feel comfortable. And so we want to ask them, what do you like about tobacco use, if anything? How does it fit into your life? And this is where somebody say, well, it helps to relieve stress, or just relax, it keeps my hands busy. It's just what I do. It's part of my daily routine. And so, but then at that point, that gives us the opportunity to look at the other side and turn that question around. Well, what are the things that you don't like about smoking or tobacco use? Well, it's expensive, it's really, it hurts my kids. I don't want to smoke around them. My doctor's telling me my oxygen levels are decreasing, all of this. And so what we would do is kind of help them weigh that out. So kind of, acknowledge that there are things that they like about tobacco use, but really highlight the negatives, highlight any change talk. When somebody says, I need to do something, or I should start thinking about this, then we pounce on that and say, well, so this is something that you're seriously thinking about. This is, important to you. And then they can take that and kind of, expound upon that and, take that and run with that sort of change talk. Somebody who's preparing, certainly we want to always pull change talk out of anybody wherever they're at. But at that point, we start talking about maybe previous quit attempts, what challenges they had faced previously, and what they had learned from that, what maybe they think they could do this time around that would benefit them more. Certainly we encourage people wherever they're at just for calling in. We encourage and congratulate somebody for taking the first step. So those are all kinds of things that we feel like help to build rapport, increase autonomy, so the person feels like they're in charge. They decided to quit. They called in. they decided to enroll, even if they were referred to the program, it's their decision to enroll, and nobody's going to tell them what they need to do. And once they feel like they're in control, then they take ownership of their plan, and they seem to follow through with it more. So somebody who's, say, in an action stage, we would check in with them every week or two, see how their plan is coming along, what's working, what's not working. Always want to kind of talk about a quit date in this group, so we kind of set a plan for 1 week out, and then we'll maybe call them on their quit date or the day after, really whatever's most convenient for them. And then within that maintenance stage, we talk about, well, how does it feel to cut down or to quit tobacco? What are the benefits? What do people around you think? We ask about, once again, what are some challenges that you foresee coming up where you might be tempted to smoke? So we just want to increase awareness of those triggers and pitfalls around, because, like we all know, relapse happens. But the good thing is every quit attempt increases your chances of quitting successfully for good. We treat those as a learning opportunity. We don't beat somebody up. They're already upset when they slipped, and they tell us that they slipped. We try to normalize those feelings and talk about the next step. What's important. Well, how important is it for you to try to quit again? And, if somebody's not ready to get back on the horse, well, we respect that decision. When somebody wants to get back going again, well, then we're going to be right there with them. And so the cogs here kind of elaborate the collaborative and type of partnership attitude that we have here with participants. So what we want to try to get away from is this authoritarian perspective where we have all the knowledge as coaches and the person who's quitting is learning and they don't know anything. We want to empower the person to feel like their ideas are important. And even if they don't work, that's okay. And if somebody needs help, then that's where we jump in an MI adherent way, motivational interviewing adherent way. Ask, well, I just talked to somebody who was going through the same situation you were. Would it be okay if I shared some of the things that worked for them? And that way, we're not telling somebody what to do. We are getting permission first, and then they're allowing us to share. And then after that, we say, well, what out of those ideas, what might work for you? And I have used that technique hundreds, probably thousands of times, and have never had anybody who says nothing. Because it's an open-ended question. You've given them 15 different choices, and you say, out of all that, what could possibly work for you? Somebody will find one thing that they will try and say, you know what, I'm not going to drink coffee in the morning. I'm going to switch over to juice, or I'm not going to smoke inside. These are people who are trying to cut down, trying to make routine changes. So, we want to give them lots of options. One other thing, that's important in my opinion is trying to really pull out ideas from the participant instead of, just telling them what to do. So like I said, going back to their previous quit attempt, most people when they call in, they already have an idea of kind of what they're doing. And so we want to congratulate them on that and, just build upon those successes. So a couple of things I want to go over real quickly are some of the special protocols that we already have or are developing for specific populations. So, expectant women are definitely somebody that I'm sure you're targeting at the state level. Nationally, with other states we partner with, it's really important. And certainly at National Jewish Health, this is important. And we developed this pregnancy postpartum protocol several years ago. What it does is allow the participants to have a dedicated coach and specialized materials. They get specialized text messages as well. So a lot of different things to keep them engaged and going. And, the evidence shows that they're more likely to quit being in the special protocol, and they're less likely to relapse after giving birth and after quitting. So, a 55% quit rate at the end of pregnancy is something that is well above the national average. It's something that we're really proud of. So a new protocol that we are getting ready to launch here soon, one of the big challenges that we're experiencing is hiring the right coaches for this protocol. But this is the American Indian Commercial Tobacco Program. What we have found is that American Indians are more likely to use tobacco. They have a more difficult time of quitting. They don't necessarily trust traditional tobacco cessation programs. So what we've done is gone around the country, talked with tribal elders to get their feedback. We talked with a lot of people in academic institutions to develop this new protocol. And what we found that Native coaches who can share their own experiences, perhaps living on a reservation, those who can differentiate between commercial and sacred use of tobacco is very important. We, in the past, had thought of, tobacco cessation is you got to quit 100% right now. There's, nothing in between. But with American Indians, tobacco use has been a part of their culture for hundreds, thousands of years, and so it's important for us to respect and take an approach more of harmony and a journey toward peace and balance in your life. So with this protocol, we'll once again send out specialized material, so they won't have the same thing as everybody else. They'll have a special text message and email program. So to kind of go into the technology pieces, our website, quitnowalabama.com, has many different features. There's the ability for somebody to go online and chat with a coach, who may not want to pick up the phone, so it's great for people who really like to be online. So, live online chat with a coach is a great feature. There's the ability to go into forums and chat with other tobacco users online, get their thoughts, what's working, what's not working. Sometimes you don't always need a solution, but sometimes you just need to vent and get things off your chest, especially when you're going through such a tremendous change as quitting tobacco. So we love to encourage people to use all the support resources that they can. And if somebody has gone online, chatted with a coach, kind of make sure they're medically eligible and they don't have other insurances like Medicaid or Plan First, then we can order an RT for them online as well. So just another great benefit of the online program. One neat feature that people like is the smoking calculator. So you plug in how much you were smoking, how long you've been smoking, start telling you, how much money you're saving, and it's good. That's a big motivation for people. They need to put their kids through college. They need to make a rent payment on their home or whatever that may be, and so saving money can be a huge source of motivation. And so I just want to real quickly go over the other pieces of technology and all the many points of contact that Quit Now Alabama participants can be involved in when they enroll in the program. So we have an app that you can download. So if you go into the Apple Store or Google Play on your smartphone, you can go in and search QuitLogix, QuitLogix. That always kind of gets people, but QuitLogix. And you'll see the mobile app pop up. You download it. It's absolutely free. With the app, you can track your shipment of patches. If you're having a craving, you can say, it'll ask you, craving, yes or no. Yes, you get a distraction, kind of a mental, thing that pops up and just kind of, grabs your attention. It'll give you a tip of the day, so you can go on there every single day and get a new tip for quitting and just a little bit of encouragement. And then you can update your phone number. You can update your address before your next coaching call. So when we give you a call, we don't call your old phone number or something like that. We stay in touch with you. The email and text message program do have some interactive text, so we'll ask if you're feeling good, bad, or okay, and however the person responds, then they'll get a specific text message that way. We try to re-engage people if we haven't been able to contact them in a few weeks. We'll say, hey, we've been trying to reach out to you. Please give us a call back. And we do the same thing with email messages as well. We'll send somebody a text the day before their appointment to say, hey, we got a call with you tomorrow. We're looking forward to it, basically. So just so people aren't caught off guard. And then, somebody's been quit for a while, 1 month, 3 months, 6 months, 1 year, we'll send them a text message congratulating them on that as well. So we know that everybody who calls in can be at a different stage in the program. Some people are very tech savvy, and all of these different pieces of technology can be very useful for them. Others, are best suited for just a phone-only program, which is fine. We know we've got people of all different socioeconomic and ethnic backgrounds, and we've got materials to accommodate people of all walks of life. So no matter who the person is, that's a tobacco user, we want you as a health professional to feel comfortable and confident referring them and knowing that they're going to get the best evidence-based treatment, and I'll repeat that, evidence-based treatment as possible. So thank you so much for your time, and I'll look forward to any questions at the end.
Thank you, Seth. And for the audience at home or work, wherever you might be, Seth will be on the line at the end of the program to answer any questions that you may have. So up next, we have Iril Patel. She's with the Alabama Medicaid Agency, and she's going to talk more about the different FDA-approved cessation medications. Iril?
Thank you, Karen, for the introduction. So there are several barriers associated with smoking cessation. Quitting smoking has always been a challenge. And one of the biggest barriers is that it creates the nicotine dependence. Nicotine dependence is the physical addiction and psychological effect. It basically provides a feel-good effect to the people, and they use to cope up with their stress, depression, anxiety, and loneliness. And once a person stops smoking, then they can suffer from withdrawal symptoms like craving, anxiety, insomnia, headache, depression, all that. These withdrawal symptoms can last from several days to weeks. Besides that, there is also a risk of weight gain associated with smoking cessation. This is true. Smoking increases the metabolic rate, and so when a person stops smoking, their metabolic rate returns to the normal, which is good. But if the person keeps consuming the same amount of calories that they did before, then they'll put on some weight. So it is very important to talk to your patient to maintain a healthy diet and choose lower calorie food option. There are several benefits of quitting. Tobacco smoke contains 7,000 chemicals. Out of that, 100 of them are harmful, and at least 70 of those can cause cancer. So, smoking cessation can reduce the risk of lung cancer, heart disease and stroke, and it can also reduce the risk of lung problems like COPD and emphysema. So, what role does smoking cessation products play in smoking cessation? Studies have shown that when used in combination with the behavioral therapy and counseling treatment, smoking cessation products can double the chance of the success, and it can help the person to stay quit. It basically helps reduce the feeling of the withdrawal and craving. It helps in weaning the body of the cigarette, and they supply the nicotine to the body in very minimal amount without exposing the body to the harmful chemicals found in the tobacco smoke. There are several products available in the market that can help with the smoking cessation. Some of them are available over the counter, and some are available via prescription only. So, there are two types of product available in the market, the nicotine replacement product and the non-nicotine based product. The nicotine replacement product that are available over the counter includes nicotine gum, lozenge, transdermal patches. And the products that require prescriptions are nicotine inhaler and the nasal spray. And the non-nicotine based products that are available via prescription only includes the varenicline, which is also known as Chantix, and bupropion. Let's first talk about the nicotine replacement products. Nicotine replacement products are safe, but there are several precautions associated with its use. For example, this product cannot be used in the patient who had recent myocardial infarction or who has a history of serious or life-threatening arrhythmias or angina pectoris. Besides that, it is also not considered safe to be used in pregnancy or while breastfeeding. So this is the summary for over-the-counter available nicotine replacement product. The gum and the lozenge are available at the strength of 2 mg and 4 mg, whereas patches are available in 3 different strengths, 21 mg, 14 mg and 7 mg. There are some common side effects associated with all nicotine products, which includes tachycardia, palpitation, GI events like nausea, vomiting, diarrhea and abdominal pain, and also dry mouth. And some side effects are specific to specific products. For example, using the transdermal patch can cause skin problems like erythema, pruritus, and it can also cause abnormal dreams. The duration of therapy for the gum and lozenge is similar. It is 12 weeks, whereas patches, it can range from 8 to 10 weeks. And all of these products are available generically. So the dosing for the gum and lozenge is exactly similar. During the first 6 weeks, a patient can use 1 piece every 1 to 2 hours, and after completion of the first 6 weeks, during the week 7 to 9, they can increase the dosing interval to every 2 to 4 hours. And for the remainder of the treatment, they can further increase the dosing interval to every 4 to 8 hours. And it is also very important to tell the patient about the max dosage limit. For example, for the gum, the maximum dosage limit is 24 pieces a day, and for lozenge, it is 20 pieces a day. So, the initial dose of the gum is based on the number of cigarettes smoked per day. For example, if the person smokes less than 25 cigarettes per day, then they can use a lower dose of 2 mg, whereas if they smoke 25 or more cigarettes per day, then they will have to use a higher dose of 4 mg. For lozenge, if the person smokes first cigarette within 30 minutes of waking up, then they will require a higher dose of 4 mg, and if the first cigarette is smoked 30 minutes after waking up, then a lower dose of 2 mg will be appropriate. There are certain important counseling points that should be discussed with the patient when recommending this product. For example, for gum, it is important to tell them to chew the gum until the tingle is gone and to park it between the cheek and the gum. And it is also important that they chew it slowly in order to prevent the jaw ache and maximize the nicotine absorption. Also ask them to repeat the process for at least 30 minutes. For lozenge, tell them to dissolve it for 20 to 30 minutes and also ask them to avoid chewing or swallowing. And one important point is that they should not have any kind of food or drink 15 minutes prior to or while using gum or lozenge. One important thing to tell them is about the max dose limit, as I mentioned earlier, because if they overuse this product, then it can cause side effects like heartburn, nausea and hiccups. There are several advantages associated with the use of nicotine gum, such as it acts as an oral substitute for the tobacco. Besides that, it delays the weight gain, and they require frequent dosing, so it can be titrated easily to prevent the withdrawal symptoms. Also, it can be used as combination therapy with other products to manage the cravings. There are also disadvantages, which includes like it requires frequent dosing. For example, during the first 6 weeks, the patient might need to take 1 piece every 1 to 2 hours, and this might not be convenient to some patient. Also, if the patient has significant dental work, then it can be a problem. Also, gum requires efficient chewing techniques since it can cause adverse event, and chewing gum sometimes is not appropriate in certain situations. There are advantages of lozenge. For example, the advantages of lozenge are exactly similar to the gum. It acts as an oral substitute, it delays the weight gain, it has easy titration, and it can be used in combination with other products. The disadvantage of the lozenge is that it requires frequent dosing just like the gum, and it can cause side effects like nausea, hiccups and heartburn. Now let's talk about the nicotine transdermal patch. So the dosing and the administration for the transdermal patch is product specific, however it generally involves 3 steps. It includes step 1, step 2 and step 3. Patients smoking 10 or more cigarettes per day will have to start at step 1, where they will have to apply a patch of 21 mg per day for at least 6 weeks. And after this 6 weeks, they can move on to the next step, which is step 2, where they will have to apply a patch of 14 milligram per day for at least 2 weeks. And after completing these 2 steps, they can move to the last step, step 3, where they can apply the lowest dose of patch of 7 milligram per day, and they'll have to do that for 2 weeks. If the person smokes less than 10 cigarettes per day, then it will be okay for them to just start at step 2 and can remain on the step for at least 6 weeks and then move on to the next step. Also, it is very important to tell the patient to wear this patch for at least 16 or 24 hours in order to get the maximum benefit out of it. Initially, when starting therapy with the transdermal patch, there might be certain dosage adjustment required. For example, if the patient has too many side effects, then the dose might need to be decreased, and if they are still having the withdrawal symptoms, then we might need to increase the dose. Also, we need to make sure that if we are using this patch with certain medications like cimetidine, we need to dose adjust, since cimetidine can increase the serum concentration of nicotine and it can be toxic. There are several advantages with the use of patch. One of the biggest one is that it just requires once daily dosing, unlike gum and lozenge, which will be very convenient to the patient who doesn't like to take nicotine product every now and then. Besides that, just like gum and lozenge, it can be used in combination with other products. And other big advantage is that it provides the nicotine level consistently for over 24 hours. Disadvantage of the transdermal patch is that just because it's once daily dosing, it cannot be titrated easily for the acute withdrawal symptoms, and also it cannot be used in people who have skin problems like psoriasis, eczema, and dermatitis. We already talked about the nicotine replacement product that was available over the counter, so now let's talk about the products that are available only via prescription. This includes nicotine inhaler and the nicotine nasal spray. Inhaler is available as 10 milligram cartridge and nasal spray is available as 10 milligram per ml. Some of the common side effects of the inhaler are headache, mouth irritation, runny nose, heartburn, and hiccups. And some of the side effects of nasal spray include runny nose, sneezing, cough, and nose irritation. The duration of therapy for inhaler can range anywhere from 3 to 6 months, whereas for nasal spray it has to be 3 months. And both of these products are only available as brand, so they are going to be more expensive compared to the other generic product available. So for the dosing for the inhaler, the initial dose is 6 to 16 cartridges per day for at least 12 weeks, and the maximum dosage limit on inhaler is 16 cartridges per day. After completion of the first 12 weeks of therapy with the inhaler, the dose can be gradually decreased over 6 to 12 weeks. And since the duration of the therapy is 3 to 6 months, it is also important to tell the patient that they should not be using this product for more than 6 months. Advantages of the inhaler is that just like gum and lozenge, it acts as an oral substitute for the tobacco. It can be easily titrated to manage the acute withdrawal. Also, one specific advantage is that it mimics the hand-mouth technique of the smoking, so it can give the person the feeling of smoking a real cigarette. Besides that, it can also be used in combination with other products. The disadvantages are that like gum and lozenge, it requires frequent dosing, which is inconvenient. Also, cartridges are sometimes not much effective in extremely cold weather. And we need to be careful while using this in people who has lung problem like bronchospastic disease, since it can cause airway irritation. The usual dosage for the nasal spray is 1 spray in each nostril 1 to 2 times every hour as needed. And initially, when the person is starting with this therapy, they might require at least 8 or more doses per day. And the max dosage limit on the nasal spray is 5 doses per hour or 40 doses per day. Advantage of the nasal spray is that it can be easily titrated and it can be used in combination with other products. The disadvantages includes that it requires frequent dosing, it can cause nose irritation, and we cannot use this in people who has chronic nasal problem or severe airway diseases. Now, let's talk about the non-nicotine based products. This includes varenicline, which is also known as Chantix, and bupropion. Varenicline is available at the strength of 0.5 mg and 1 mg, whereas bupropion is available as 150 mg sustained release tablet. Some of the common side effects of varenicline includes nausea, vomiting, headache, abnormal dreams, insomnia, and suicidal behavior. Common side effects of bupropion are like fast heart rate, headache, insomnia, nausea, and suicidal behavior. Varenicline can be used for 12 to 24 weeks, whereas bupropion can only be used for 7 or 12 weeks. Varenicline is only available as brand name, whereas bupropion is available as brand as well as generic. So let's first talk about varenicline, also known as Chantix. So how does varenicline work? Varenicline is a partial agonist at the nicotinic receptor which are located within the brain. So varenicline binds to this receptor and blocks the action of nicotine. It basically prevents the nicotine stimulation of the mesolimbic dopamine system, which is associated with the nicotine addiction. Varenicline stimulates the dopamine activity, but to a very lesser extent, and in doing so, it can help with the craving and withdrawal symptoms. Besides that, also if the person continues to smoke, then varenicline competitively binds to the nicotinic receptor and prevents that addiction. Varenicline is safe and efficacious. However, there are several warnings that we need to be careful about. For example, it requires dose adjustment in renal impairment, and it has black box warning for neuropsychiatric symptoms. The dose for varenicline will need to be titrated over several days to weeks. For example, during the first 3 days, a patient will have to use 0.5 mg once every morning. On the next 4 days, they can increase the dose to 0.5 mg 2 times a day, and for the remainder of treatment, they'll have to use a 1 mg dose for 2 times a day. Some important things to keep in mind when prescribing varenicline is that varenicline should only be prescribed to the patients who are motivated and who are determined to quit smoking, and they will have to set a quit date. And the therapy with this varenicline will need to be initiated 1 week before that quit date. Also, it is important to tell the patient to make sure to take this drug after eating or with a full glass of water in order to minimize the side effect of nausea. Also, check for the patient's renal function, since dose adjustment might be required if the creatine clearance is less than 30. The duration of therapy for the varenicline is 12 weeks. However, the patient who are successful after first 12 weeks can be treated with additional 12-week course of therapy to increase the chance of long-term abstinence. And those patients who are unsuccessful with the first 12 weeks of therapy should make a second attempt once the factors contributing to the failed attempt have been identified and addressed. Advantages of using varenicline is that it's just twice daily dosing, so this is very convenient and it can improve adherence. Also, it works differently, so it can be beneficial to the patient who have not had success with the other treatments. Some of the disadvantages is that it should be taken with food or a glass of water in order to minimize nausea. Besides that, it has the black box warning of central nervous system symptoms, so a close monitoring is required. And its safety and efficacy has not been established in children less than 18 years of age, so we cannot use this drug in those age group. Now let's talk about bupropion. So bupropion is an antidepressant and it is a dopamine norepinephrine reuptake inhibitor. It works by increasing the level of norepinephrine and dopamine within the brain. Increasing the level of norepinephrine can help with the withdrawal symptoms, and increasing the level of dopamine can decrease the craving. There are several warnings with the use of bupropion. For example, it has the black box warning for suicidal ideation, so it is very important to tell the patient and their family members to monitor any kind of suicidal act. Besides that, it can also cause central nervous system symptoms like mood changes, hallucinations, agitation, anxiety. So just counsel your patient on that. And it has the risk for seizure potential, so it cannot be used in patients who have history of seizure. Besides that, it requires dose adjustment in hepatic impairment. Also, we cannot use bupropion in people who have eating disorder like bulimia or anorexia nervosa. And its use is contraindicated with the therapy of monoamine oxidase inhibitors. So, the dosing for bupropion is pretty simple. For the first 3 days, a patient can use 150 milligram once every morning, and after that they can increase the dose to 150 milligram 2 times a day. And the max dosage limit for the bupropion is 300 milligram per day. And also make sure to check the renal function and hepatic function of the patient, since dose adjustment might be required. Just like the varenicline, even with the bupropion, patient will have to set a quit date, and the therapy will need to be initiated 1 to 2 weeks prior to the quit date, and the therapy can be continued for 7 to 12 weeks. However, some studies have shown that maintenance therapy with 300 milligram even for 6 months were efficacious. Also, it is important to tell the patient to avoid taking more than 1 dose within 8 hours, since bupropion is a sustained release formulation and it can cause overaccumulation of the drug if taken more than often. Also, you can counsel patient to avoid taking this drug at bedtime, since there is the risk of insomnia associated with its use. Some of the advantages of the bupropion is that just like varenicline is twice daily dosing. Besides that, it can help with the weight loss, and also it is an antidepressant, so it can be beneficial in patients who suffer from depression. Also, just like other products, it can be used in combination with the other products. Disadvantage of using bupropion is that it has the increased risk of seizure potential, so we cannot use this in the patient with the history of seizure. Also, it has several warnings and precautions. For example, it can cause central nervous system symptoms, and it has also a warning for the suicidal behavior. And just because of these symptoms, a close monitoring is required. So, how does Medicaid play a role with these smoking cessation products? Beginning of January 1st, 2014, Medicaid started covering for all nicotine replacement products. However, a prior authorization is required, and the recipients must enroll in the Alabama Department of Public Health Quitline. There are certain exceptions to this requirement. For example, planned first patient and pregnant female does not require a prior authorization. This is the prior authorization form that will be required to be submitted, and this prior authorization form and the Quitline referral form must be faxed to the health information design, and additionally the Quitline form should also be faxed to the Quitline vendor. These forms are easily available on the Medicaid website. You'll just have to go on the pharmacy service or DME page, and it can be easily found under that page. And you can also find this form on the quitnowalabama.com, and here you will have to click on a Medicaid postcard image, and it will take you to that page. Thank you, and I'll be happy to answer any questions.
All right, thank you so much, Irel. Up next, we have Leanne Hickson. She's the manager of the Plan First program, and she's going to talk about the benefits for recipients in Plan First. Leanne.
Alabama's Plan First program is a family planning program for women ages 19 to 55. Plan First provides a yearly family planning exam, care support from a social worker or nurse, and a variety of types of birth control, such as birth control pills and Depo-Provera shots. We also provide tubal ligations for women 21 years or older, lab work such as testing for pregnancy and STDs, help in planning when to have a baby, and as of 2012, the tobacco cessation program. And with the 3-year extension that was just announced in January of the Plan First program, we will be covering vasectomies for male. However, coverage for these vasectomies will begin mid to late 2015. Medicaid will let us know when that will be available and also how we're going to enroll these males. Why is tobacco cessation included? First, there's the high tobacco prevalence rates. According to 2014 Behavioral Risk Factor Surveillance System, 18% of females in Alabama smoke. 21% of female smokers in Alabama are ages 19 to 55. As you can see, females in the Plan First age range have a slightly higher prevalence rate compared to Alabama females overall. Alabama continues to have the highest smoking prevalence rates, males and females, in the U.S. and in the U.S., Alabama ranks 21.5%, whereas the U.S. percentage rate is 18%. The second reason tobacco cessation is included is preconception health. Every woman should be thinking about her health, even if she is not planning to get pregnant. Even with use of birth control, pregnancy sometimes happens. It is important that a woman lead a healthy lifestyle so that if pregnancy does occur, their baby will have a healthy start in life. A healthy lifestyle means avoiding risky behaviors such as smoking, drinking, using drugs, overeating, and or having multiple sex partners. The goal is to have the patients adopt healthy lifestyle habits that include plenty of rest, eating a healthy diet of fruits, veggies, and whole grains, taking a multivitamin with folic acid to prevent certain birth defects, getting tested for STIs, visiting their primary care physician and dental provider on a regular basis, and staying up to date on important vaccinations. The bottom line, the time for a woman to take care of her body is before she gets pregnant, so that when she does get pregnant, her body will be ready to handle the pregnancy. About half of all pregnancies are not planned. By quitting tobacco use before pregnancy, multiple problems that can occur during pregnancy can be avoided, such as infertility, miscarriage, preterm delivery, stillbirth, low birth weight, and sudden infant death syndrome. In addition to those above, CDC states that smoking can also cause difficulties like placental abruption, premature rupture of membranes, and birth defects such as clubfoot, cleft lip, or cleft palate, and attention deficit hyperactivity disorder. What tobacco cessation benefits are available? It's a two-pronged approach, coaching and medications. The rationale is that the telephone quitline counseling is effective with diverse populations and has a broad reach. And providing medication in addition to counseling significantly enhances treatment outcomes. The bottom line is that coaching plus nicotine replacement therapy significantly increases the chances for successful outcomes. Since Errol has gone over the nicotine replacement therapy medications, I'm just going to let you know that recently I've been told that ADPH will begin covering the gum and lozenge April 2015. Currently, we only cover the patch. Private providers can prescribe any nicotine replacement therapy that is paid for by Medicaid, and that list is available on their website. How are the benefits accessed? First off, you have nurse management. If the patient is already approved for Plan First, they will assess the patient's tobacco use and quantity. They will inquire if the patient is interested in the cessation program. If yes, the patient must be under the care of the health department with a medical history on file prior to prescribing the NRT patches. If the patient is being seen by another Plan First provider, refer her to the location for the smoking cessation therapy. Inform the patient about the Alabama Tobacco Quitline and what services are provided. Once the patient has been assessed by the nurse or the nurse practitioner, the patient meets with the social worker who completes the Plan First Smoking Cessation Program patient referral consent form and then faxes it to the Quitline. The social worker also explains the purpose of the Quitline. It is important to know there is no prior approval required under the Plan First program. The nurse practitioner will review the patient's medical history, and the patients with contraindications may be reassessed at a later time for NRT per the nurse practitioner discretion. They will prescribe nicotine patch based on tobacco use history and quantity. Heavy tobacco use, 10 or more cigarettes per day, and/or uses other tobacco products. They will receive 21 milligrams for 6 weeks, then 14 milligrams for 2 weeks, then 7 milligrams for 2 weeks. Light tobacco use is less than 10 cigarettes per day. They will receive 14 milligrams for 6 weeks, then 7 milligrams for 2 weeks. They will then be refer the patient to the care coordinator to complete referral to the Quitline. The care coordinator role is to discuss the Quitline with the patient and to complete the fax referral. They will advise the patient that a prescription can be filled at any local pharmacy, and they will follow up with the patient on a quarterly basis. This is the patient referral consent form for the Alabama Quitline. The care coordinator will follow up with the patient 10 days after the initial appointment of receiving prescription of the NRT. They will inquire if the patient filled the prescription and if they have any issues. The care coordinator can help resolve, and they will ask if the Quitline staff has contacted them yet. As stated on the slide, follow-up is quarterly thereafter. The Quitline's role. The Alabama Tobacco Quitline staff will contact within 24 hours of referral. They will help develop an individualized quit plan, and they provide ongoing support from Quit Coach, and they will provide 5 coaching calls. A brief survey call will be done 7 months after registration. Program evaluation is done by the UAB School of Public Health. They have completed a recent evaluation of the Plan First Tobacco Cessation Program, and they determined that over 15,000 participants were referred to the Quitline between November 2012 and February 2014. Approximately 28% of the participants who were contacted for follow-up quit smoking at some point during the evaluation period. Successful quitters were more likely to have used both NRT and the Quitline. Evaluation of the Quitline statistics show the program is having a positive impact on the Plan First population. Karen?
Thank you so much, Leanne. Just as a quick summary, it's up on your screen now. Tobacco use continues to be a heavy burden in Alabama and the United States. We've gone over these brief interventions with you, and these interventions will increase the likelihood of your patients making quit attempts. The AARP intervention that Julie went over with you, it's going to help you save time, and it also ensures that your patients are getting the full tobacco intervention. Additionally, the Medicaid and Plan First are covering cessation medications, so be sure if you have patients that are in either of those programs, to discuss those medications and prescribe them when appropriate. So I believe that wraps up all of our presentations, and we do have just a few questions. Seth, are you on the line?
Yes, I am.
All right, we have a question, and this person is wondering about how long does it take for a patient to receive the patches from the Quitline?
Sure. So after somebody orders patches, which, as soon as they're referred and they take the first call and get enrolled, we can order patches for them that day. We quote 7 to 10 business days for it to arrive at their home. But generally, it can happen even sooner than that, within just a few days. So really 2 weeks at the max.
All right. And one more question for you, Seth. This came from a doctor who says, what if my patient tells me that the Quitline never called me?
Well, the physician would certainly be more than welcome to reach out to us, and we can do some follow-up. If it's possible, I mean, feel free to provide my email address, phone number, or I can do that. Either way is fine. But I mean, we certainly don't want that to happen. We want to follow up on every single referral and, you know, reach out to every person. So if something like that has come up, please reach out to me so I can follow up to see if there was a problem with the facts in itself. Sometimes they're illegible, and so it's difficult for us to get a phone number or something like that. So there could be a few different things that may have contributed to that, but we certainly want to get to the bottom of it and support the person in quitting tobacco.
All right. Thank you, Seth. We also have 2 quick questions for IRL and Medicaid. Audience is wondering, what are the patient copays for the nicotine replacement therapy or prescription meds?
The copays for any of this product can range from 65 cents to $3.90, depending on which product they are buying.
Okay. And another caller was wondering, what's the turnaround time for the PA? You send that to Health Information Designs. How quickly can a patient go to the pharmacy and pick up their meds?
Most of the PA approval, like 98% of the PA approval, can occur within 8 hours or less. However, we have a rule that we have to approve all the PAs within 24 hours.
Okay, great. Thank you so much. That is all of our questions that we have for now. If additional questions come up after you viewed this program, feel free to contact myself, Karen Atkinson, or Julie Hare here at the Tobacco Control Branch. Our information should be attached to the slides and materials that are available online. This program will also be available on demand, and remember that you can get continuing education credits for up to a year. Expires March 31st of 2016. So thank you, everyone, for your attendance. Thank you, ladies. Thank you, Seth, for providing this valuable information to our healthcare providers out there.